us. This is Paul Margulies. I'm from the Center for Practice Innovations, and joining me as co-presenter is John Lee. John is Director of CCSI and NYCCP, and together we're going to try to do something very interesting. We're going to take a 6.5-hour workshop and give you the highlights in the next hour and a half or so. So fasten your seatbelts and bear with us, and we're going to really review quite a bit of material in a relatively short period of time, but hopefully do it in a manner that really the important points jump out at you. And so I'm going to move along, and what you can see here is a very quick agenda, and you can see basically John and I are going to be trading off, talking about the first round of training that occurred quite some time ago. John's going to talk specifically about systems transformation and what's going on in New York State. I'm going to talk a little bit about this initiative and especially about supervision of care managers, and we'll take it from there. And just for folks who are aware, and I think you are aware of this, this is really a makeup for a face-to-face meeting that was held in all 3 regions in February. But weather got in the way of a number of folks being able to join us, so we thought it would be important to at least get the highlights out to you today. Okay, so very, very quickly, this is really the second round. This is a renewal of a grant, and this is the second round where we're working with care managers and their supervisors. There are recordings available, recordings of the webinars that are available to you from round 1, and here are some screenshots. And if you would like your staff or yourselves to avail yourselves of these archived webinars, you can find them in our learning management system. If you have any questions about that, you can contact any of us and we'll help guide you through that. And without further ado, I'm going to turn things over to John.
Thank you very much, Paul, and good afternoon, everybody. Yeah, my part in this presentation is to give you an overview of what's happening in New York State, specifically tied to Medicaid managed care reform in support of those with behavioral health needs. So I have a number of slides. As Paul said, there's a lot of information here that we think is helpful. We're not going to hit on all of the slides in the same level that we might have before, but you've got the information if it's helpful. So what we cover today is a little bit of why is there reform taking place within Medicaid. You're going to get a real short course on Medicare. It's not 101, it's just 01 today. Some limitations of the current New York State Medicaid structure, and then what's ahead. And really, in terms of talking about what's ahead, we're going to do this request for qualification that has gone out to Medicaid managed care programs, and I can give a lot more detail on that. So that's what we're going to talk about. So in terms of setting the stage, why is there reform Medicaid? Well, you may have heard this quote before. The governor a number of years ago said, Medicaid is an important program for us, but at this point we're spending a lot of money and we're really not seeing significant measurable improvement in of the individuals that we're supporting. At the time there were 5 million Medicaid recipients. That number's probably grown a little bit. But basically he said we need to think different about what we're going to do to have an impact on improving outcomes and managing the costs for the Medicaid program. Expected outcomes you see here: improved status, improved quality of care for individuals, along with reduced costs. One of the key themes, and it's important to point out here with this group, is the notion that care management for all will have an impact. So when you talk about money, how much are we talking about? In 2013, there were $49.1 billion spent to support over 5 million individuals. And in many situations, like many situations, we see that in those dollars, a vast majority of those dollars are in support of a relatively small number of individuals. So that is our focus, those individuals that are high need, that really need some support and guidance to move forward. Care 101, many of you understand what managed care is. To give you the definition, it's an integrated system that manages health services for an enrolled population, rather than simply providing or paying for the services. It links the services and the costs together. Some of the key ingredients in successful managed care is really focused on care management, and that is not just disease management and utilization management, but the coming together of those two themes. It really integrates services, and a key component is financial risk sharing with providers. And again, we're talking about general managed care, not necessarily how Medicaid managed care works today. So goal of managed care is really to control costs by carefully looking at services, making sure that as appropriate individuals are receiving services that they need and are not receiving services that they don't. Focusing on service quality, look at population health. This is really managing chronic illnesses, managing services that will really prevent illnesses from evolving for an individual. Some of the key components, it is a network of providers that are contracting with the managed care company, either on their own or through an independent practice association. Prior approval is required in a lot of different kinds of services, not all in all cases, but it really does depend on the benefit package. And there are utilization management practices. Typically what happens for a managed care company, I think this is important for all of us to remember, is the managed care organization is essentially receiving a fixed amount of money per month to support the needs of that individual. So the number isn't going to go up if they have more admissions or less, or if they have less admissions. It really is up to the managed care company to figure out how to best manage not only the cost of care for the individual, but the outcomes. So it's an important philosophical element of successful care. Providers can get paid in many different ways, and that's work that the state can use to consider as they think about a new model for Medicaid managed care, but paying based on impact. So in terms of determining if services are going to both be paid or provided and paid, when you have somebody that's a part of a managed care plan, it's always important, one, to make sure that person is currently a member of the plan, that the service being provided is a part of the member's benefit plan, that the service is really medically necessary, and that conversation can take place through utilization management. If it's an authorized service, has it been authorized? And very, very important, is the provider that's delivering that service a part of the managed care network? Because unless you're answering yes to all of those questions, then there's always a chance that that service is not going to be paid for. Physicians can be organized in a lot of different ways, and that's a conversation for another time. I want to take a little bit of time, though, to talk about the state Medicaid program, what it looks like today, and you see this interesting slide to really try to convey that there are Medicaid recipients, and you can see them off to the left. They are getting services from a managed care organization, but many times the managed care organization, especially today, isn't responsible for all of this. It's only a subset of the service that individual needs. So there's this element of services being provided that are covered by Medicaid but considered out. So they're handled on a fee-for-service basis. There's also other service that an individual gets that really isn't covered by Medicaid but funded through a community organization or a county. All of those come together to really meet the Medicaid recipient. But if they're not all through the managed care company, there is a question about who for the whole person to make sure the needs of the individual are being met. You also have a category of folks that you see off to the right. They really are high-need individuals, and there have been exceptions in terms of their participation in Medicaid managed care. So these things that you see today are parts of what you're going to see change in the future. But just to make sure we're all on the same page in terms of where we are today. When we talk about the need for change, it's worthwhile to look at this chart and think about whether you believe that these indicators of performance for our system in New York State are really reasonable. What you chart is you have indicators for both New York City, which is in blue, and for the rest of the state, which is in red. At least that's the color that it looks like for me. The first you see is for, again, for calendar year 2012, the 30-day readmission rate. What you see here is benefit administration. This was the document that was released to managed care organizations, principally in New York City at this point, that were interested in providing benefit administration for individuals in the Medicaid program that have behavioral health needs. It was issued by the state probably not quite a year ago as a draft, and then reissued not quite that long ago, with the expectation that interested managed care companies will respond to this request and explain to the state how they will be successful in thinking differently about these services. The reason this is important for us to look at is these are expectations being placed upon the managed care organization, and in turn, the managed care organization will be placing these expectations upon providers of services. So really, the purpose of the RFQ was to define the expectations for managed care organizations that will support this high-need behavioral health population. So let's talk a little bit about some of the changes that are included in the RFQ. So one of the things that's different is pretty much all Medicaid recipients will be members of a managed care plan. More services, including recovery services, are going to be covered by managed care plans. These are Medicaid managed care plans. And we're going to talk a little bit more about what services will be included that haven't been included in the past. Also, individuals that have a significant need, mental health or substance use need can be a part of what's called a health and recovery plan, and that will entitle them to receive services that are not available to others in the behavioral health plan, services that, though, will be covered by Medicaid, by the Medicaid managed care plan. What's also significant here is that the RFQ really works diligently to embed key processes and resource changes that are really in line with a very specific philosophical model. So some of the themes of these models, which I think you guys will relate to and ultimately understand how important they are, is we need to do our work in person-centered, recovery-focused manner. So we need to believe in the hope of recovery for the individuals that we're supporting and understand what their needs are. It does rely on care management for high-need individuals. Again, that's part of the reason why health home care management was created. It does really push for greater reliance on community services rather than inpatient services. Consistent with DSRIP, consistent with the goals of health home, we're really looking to make sure individuals get the right kind of service at the right level of need and at the right time, and lots of times those are community services. Focuses on service integration. I've given you a couple of examples of opportunities for us to improve the integration of behavioral health services with physical health services. That's certainly one area. Integration of mental health and substance use services is another area. But any opportunity to really integrate the services, even in the continuum of care. And then there's clearly a greater accountability on really achieving outcomes. So what that means is there's the intent of being clear on what changes the state wants to see that will be achieved by the managed care companies, as well as clarity in terms of what's going to be measured to determine whether that those changes have been achieved. So covered populations, it is, in this particular managed care plan, it is mainstream managed care folks. All mainstream Medicaid eligible enrollees, they have to be 21 years of age or over and require behavioral health services. Important to point out that if somebody is duly enrolled Medicaid and Medicare, they're not eligible for this plan. But as we said, there's an extended benefit package, and so I'd like to share with you what some of those services are. So what you see in this list are Medicaid reimbursable services that previously were covered only at Medicaid, by Medicaid on a fee-for-service basis. So they were never in the benefit plan for the managed care companies. So come January, well, very soon, it depends on what part of the state you're in, managed care plans will be paying for continuing day treatment, for partial hospitalization, for personalized recovery-oriented services, for ACT, for rehabilitation services for residential SUD treatment supports, inpatient psychiatric services. Currently, it's fee-for-service for all SSI Medicaid recipients, so that will be coming in, and rehabilitation for services for residents of community residences beginning in year 2. So again, what you're seeing is more of the services that have been paid for by Medicaid in the past will be covered by the managed care company, with the expectation that the services will be well coordinated and the individuals will be getting the services they need at the right time. Health and recovery plans, I mentioned this before. Hopefully you've heard about HARPS before, because it does also relate to the work of health home care management. But again, a HARP is what's considered a health and recovery plan. Managed care companies that want to provide a HARP program, they had to apply and demonstrate their competency to meet the higher level of expectations for the management of these benefits for individuals that have higher service needs. So who's eligible? It's individuals that meet the target criteria and risk factors, as well as need-based criteria that have been established by the state. And the state anticipates that there are about 140,000 individuals that will be eligible. 60,000 will be in upstate New York. All of those individuals will be expected to have a health home care manager. And what you see is the target criteria: Medicaid enrolled 21 and over, an SMI or SUD diagnoses, eligible for mainstream enrollment, not duly eligible, and not participating in OPWDD services. You have a couple of slides that follow that also share the specific risk factors for those that are going to be eligible for HARPS. And they're worthwhile pointing out, but we're not going to spend a lot of time on them. But the expanded benefit package for those that are based upon the risk criteria eligible, that will be determined through a conflict-free functional assessment. And right now, the state is preparing to roll out the Inter-I tool as a tool for really assessing the specific needs of the individual. And that will help define what of the HARP services a person will be eligible for. And the next slide actually shares the list of services that will be covered by HARPS, or Health and Recovery Plans. And again, these will be paid for by the managed care organization if the person is deemed eligible for these services through the participation in this assessment being done through the Inter-I. More will be coming out about the Inter-I as an assessment tool. But what's important to see is, for the first time, individuals will be able to receive rehabilitation services such as described here, and the company or the agency providing that services will be paid for it. They will be able to receive peer support. They will be able to receive habilitation services, respite, non-medical transportation. Lots of times folks have said a big issue with transportation. For those that meet the requirements through that assessment, that will be made available. Family support training, employment supports, educational support services, and supports for self-directed care. And as I understand it, the state is anticipating that there will be a pilot tied to self-directed care. But again, it's really worthwhile pointing out that in this system fully rolled out for an individual that is eligible for a health and recovery plan, they have the services that were always available through Medicaid managed care. They have additional outpatient and other kinds of support services that were paid for by Medicaid on a fee-for-service basis that now will be coordinated by the managed care plan, as well as the availability of these sorts of services that we believe will have the ability to support the individual's recovery. And these are all covered by Medicaid managed care as long as the needs for those services have been identified. So that's an overview. And what I wanted to do is spend a few minutes going into some of the specifics that are contained in the request for qualifications for benefit administration. And again, These are the expectations being placed upon the managed care companies. The managed care companies in the city have already responded to this RFQ, anticipating that they're going to go live July 1 of this year. Upstate, it's expected, actually considered the rest of state, because only New York City is going live July 1. For the rest of state, the state is expecting to re-release the RFQ, kind of updating it based upon its experience in New York City, with the expectation that the managed care companies in the rest of the state will be responding and be ready to start rolling out services come January 1st, 2016. So what I'm going to go over is the vision, the goals, some of the operating principles, and the expected outcomes. All of it should hang together. As you can see, the state really making an effort to make sure this managed care approach is one that respects the needs of the individual and provides the kinds of services that will support the recovery of the individual and their ability to move into being a contributing part of the community. We mentioned these before, elements of the vision that I think are really important: being person-centered, recovery-oriented, integrating services, being data-driven, and determining the types of services you're providing and the effectiveness, and really, as it says, being evidence-based in what you're delivering. The goals of this initiative, it really is system reform goals. They're looking for improved health outcomes. They're looking to move from an inpatient-focused system to a recovery-focused outpatient system of care. And as you can imagine, that's a pretty significant undertaking, but it is also one of the priorities of the work that's being taking place across the state with respect to DSRIPs, thinking about, okay, what kind of capacity needs to be made available in various parts of the state for the services that will be community-based so that we can reduce our reliance on inpatient services. Of course, impacting access to the comprehensive array of community-based services, and that all-important integration of the physical and behavioral health services along with care coordination. And certainly, as they say, program innovation needs to take place. That's being promoted through DSRIPs, that's being promoted through health homes, and that will also be promoted through the work of the managed care organization. Other goals include the use of evidence-based practices, cross-system collaboration with the state and other local resources, assuring that the services that are being provided are delivered in a culturally competent fashion, and that we do have, for people in need, access to the network that will support their needs. And that means not just access within a month, but that's access within a timely basis. I'm going to hit some of the operating principles somewhat quickly because what they really do is they reinforce the vision and the goals. Of course, efficient and timely service delivery, care coordination and care management, access to care management and clinical management. Again, remember, these are expectations being placed upon the managed care organizations to, as we say, make sure for the individuals with the need they have access to care management. They also are really expecting us to really bump up our game when it comes to enhanced discharge planning, really thinking about that transition in care for an individual and making sure as they move from one level of care to the next, inpatient, into the community, that they have all of the services and the supports they need to be successful, to reduce the need for a readmission. Medical necessity determinations. Again, as you move into managed care, that comes with expectations that there may be some additional utilization management taking place for some of these services that the managed care companies are now paying for. But the vision here is that the medical necessity determinations that consider the level of need also consider the environmental factors and available resources and the psychosocial rehabilitation standards. So really in thinking about whether this is appropriate for the individual, it needs, the managed care company really needs to think as broadly as possible about what's right for that individual. Use of data-driven approaches for performance management and a heightened quality of care monitoring is really expected. So both of these say, hey, it's going to be so important for us to really determine what it is that we measure that matters, that demonstrates impact, and making sure that our measurement practices are done with integrity. Another operating principle is to embed into this practice financial structures that support or incentivize achieving systems goals. If you're seeing what's being released by the state, you'll see information now about their thinking around kind of value-based contracting, pay for performance. There's a lot of different ways of describing this, but really what they're encouraging managed care companies to do is to not simply pay for each unit of service, but to make sure that the services provided do have an impact, that there's a measurable impact. And this is going to be, interesting work for all of us as those conversations continue. But what it means for us today is to really make sure we're paying attention to our ability to demonstrate that we are having an impact. Our services make a difference. And certainly you see at the last one, enhanced pharmacy management, that's really significant in terms of our ability to impact the system, to really pay attention to how new medications are explained to the individual, that they have access to the medications, that if questions arise, that they have a way of getting those questions answered, that we're doing that with a reflection on what other medications they may be on and any potential drug interaction. So there's a lot of categories of opportunities around pharmaceuticals. This is the set of expected system outcomes. This is what the state is saying. If the managed care companies are doing their job, this is what we will see. So, first one is improved individual health and behavioral health life outcomes. Second is improved social recovery outcomes, including employment. So, hey, the state's putting it on the table. What we see as an appropriate expectation for the managed care organization and their network of providers is that they're not only just meeting the medical needs of the individual, but they're really looking for opportunities for improving the quality of life and the social needs of that individual. Obviously, given everything we've said so far, is that they are expecting that there will be reduction in the use of emergency rooms, really a reduction in the use of unnecessary, inappropriate emergency room. Not to say that it shouldn't be used, but certainly when we talk to individuals that are using the emergency room frequently, lots of times they say, well, that's the only place I know to go. That's the only place I can get access to services. So again, as a care manager, it's really so important for you to think about the importance of that crisis plan in ultimately making sure that the individual that you're supporting has an appreciation of the array of options that they have prior to going to the emergency department. And also the reduction in the use of repeated hospitalizations and rehospitalizations. Again, we shared before that so if we look at the state as a whole, we're at around 22, 23%, and we think there ought to be an opportunity to do better. So the state is still responding to aspects of this RFQ, and as you would expect, work continues to be done on really getting clarity in terms of the role of the health home in conjunction with the role of the managed care organization. I think that's going to continue to develop, but those roles are so important, as you can imagine, because more and more of the managed care organizations are the ones that are going to be paying the bills, so they need to see impact. So again, as you look at this information, ponder the impact to your organization. Ponder the impact as a health home care manager, and I would say, hey, this means great opportunity, not without accountability to having an impact, but even if you just think of the number of HARP eligible individuals out there that are going to need care management, a great opportunity as we move forward. So what does it mean to your organization, and what might you do differently moving forward in order to be prepared for these changes? So health home care management, you guys know health home, so we're going to quickly move through these slides about what is a health home. Again, you should know that it's care management for high-need Medicaid recipients. And we're going to move to, keep going here. Next slide. Okay, desired health home outcomes. We won't spend a lot of time on this, but it's so important for us to realize that in moving forward with health home rollout, which now, 2 or 3 years ago, depending on what part of the state you're in, even at that point, there was an alignment with the expectations being placed upon the health home care management service providers and what you see in the managed care organization RFQ, as well as what you see in DSRIP. Obviously and importantly, we want to see an improvement in healthcare outcomes, but there's also this expectation that if we're doing it right, we will reduce preventable hospitalizations and ER visits. So it's just a good reminder that those are the outcomes that are a part of the work that we're doing. DSRIP, I assume that lots of folks know about the DSRIP initiatives taking place across the state. You can look at these slides in more detail, but it's a tremendous opportunity in New York State to really build capacities needed across the various systems of care to improve outcomes for individuals while at the same time reducing avoidable hospitalizations by 25% over 5 years. That's the measurable outcome for all of the work that's taking place, and it really does require that we all work together in order to achieve that outcome. What I wanted to do is spend a little bit more time on slide, keep going. So all of this could be helpful to you if you don't have a lot of experience with DSRIP, but we want to go to DSRIP and the health homes. One of the things that I know we've been doing in our region is spending a fair amount of time with the PPS committees, work groups, in making sure that they're aware of health home care management. And I would suggest to any of you, if you have that opportunity, to do the same thing, because we are finding occasionally solutions are being proposed among these work groups that sound very much like health home care management, and it's so important to let the PPSs know that, hey, health home care management exists for high-need Medicaid recipients, and so importantly, it's already a service that's paid for by Medicaid, because you don't want the money that's a part of these DSRIP initiatives to be set aside for something that is already covered by Medicaid. And again, we know in our work that we've had a few aha moments from the folks from the PPSs as they've realized that hey, this is a service that can help our individuals hopefully reduce unnecessary admissions, and it's already paid for. So if we move to the next slide, what I've tried to do is I've gone through the presentation, and although that was specifically about the RFQ, I've tried to bring back times when you can see the relationship between expectations in the RFQ and the work we're doing in delivering health home care management, as well as occasionally the DSRIP. The next slide was really designed to be as concrete as possible for agencies that find themselves involved in these various initiatives to really help them see that there is a lot of alignment between these various transformational initiatives. So, example, in terms of shared goals, you know, you may be in lots of different meetings, but quite honestly, the goals for these initiatives are very, very similar. They tie to avoiding ED use by giving folks options, as well as reducing avoidable inpatient admissions. Some of the other themes that you see, and again, hopefully this is helpful to you, but maybe it also could be helpful for some of your staff that sees all this stuff going on and really doesn't see the relationship among them. The shared themes among all of these is our ability to really improve collaboration, to really improve integration across behavioral health with substance use as well as with primary care. The use of care management as a solution for improving health outcomes as well as reducing costs. Their focus on new solutions, different ways of thinking in order to improve, to achieve the outcomes, and really a focus on measurable outcomes. The requirement that we're going to have a measurable impact, an impact that we can see, that we can share with our care managers, an impact that we can share with our managed care organizations, that our work is making a difference. So the last slide is, what should providers be doing to prepare? Well, it is a question for you to consider. One of the suggestions that I have is not to do this. This is a guy with his head stuck in the sand, and these changes are going to take place. And although occasionally, you know, in the past couple of years, I've encountered folks who say, "No, it's not going to happen. I'll just wait it out." Well, we don't think that that's a good strategy. We do believe that talking these changes up with your staff is really important. If you don't already have a team that's thinking about the new world of managed care, of DSRIP, of health homes, and how that can really impact your agency and how for you to take full advantage, that makes sense. If you haven't had a chance to be a part of the Managed Care Technical Assistance Center work, that also is a great opportunity. MCTAC, and all you need to do is Google that, I think mctac.org. You'll find access to a readiness assessment, a managed care readiness assessment, and if you haven't done that, consider pulling that down and doing it with your leadership team, because it asks the questions that are rational questions for organizations that are going to be involved with managed care organizations moving forward. And if for some reason you can't find that, feel free to get back to Diane or anybody that's been a part of this webinar, and I'd be glad to track the link down and send it your way. So that is my overview of the changes that are anticipated. So now I'm really pleased to pass the presentation back to Paul.
Thank you, John. Covered a great amount of territory in a relatively short period of time. So we're going to move on. And we're going to give you an overview of this training initiative, and keeping in mind that this is a little bit out of sequence, and some of you may already be familiar with all of this. So I'll walk through some slides, and if people have any questions, feel free to type up in the chat box or, you know, let us know about that. So basically, what are we trying to do here? We're trying to help you to work with your care managers so that they can make the transition from having done case management for those who were case managers to doing care management. And as we all know, these two roles are not the same. You know, there are different tasks involved, different assumptions involved, and really a different worldview involved. So we're here to work with you, to work with your care managers, and we do believe that it's very important. You know, when we began to think about this initiative, you know, the various training entities that have come together, we thought that a really important aspect of this would be to be working directly with you, the supervisors. And in that way, you can really help to coach and guide and support the good work that your care managers are doing and will be doing as they make these transitions. And so participants in this initiative, as you well know by now, are the care managers, but for today's purpose, are you the supervisors as well. We began a little while ago. We're going to go about a year into the future. We have lots of stuff we're going to, you know, provide you with, and it's all going to be wrapped around something we're calling learning collaboratives. And the long and the short of a learning collaborative is this is really structured opportunities where people can learn from each other. And so you certainly will have people from